All right, looks like we're live.
All right.
Sweet. So I'm at Dorbatz at Fit Muscle and Joint Clinic, and we're going to bring the next installment of our physician interview series. And today I got Leslie Michaud with me. She's a primary care sports medicine physician, and she specializes in biologics with stem cells and PRP injections. If you want to look at our other YouTube videos with all of our other interviews with the physicians, just check out our YouTube page. But today, we got Leslie in here with us, and I got the pleasure of being able to shadow her. And there's a lot of really cool progressions on how far we've come with the biologics, and hopefully we get to learn a lot more today, and hopefully everyone watching can take something home with them today too. So Leslie, if you want to start off just with your background and how you got to the point where you're at today.
Sure. Yeah. So I'm originally from Chicago, and I did my medical training at the University of Illinois at Chicago. Originally, I did my internship and my residency in family medicine, and I did that in Rochester, Minnesota at the Mayo Clinic. After that, I went and practiced for about a year doing just primary care type medicine. And I actually, about 3 months in, switched to doing occupational health, which is mostly musculoskeletal injuries in workers. And I was always kind of drawn to musculoskeletal medicine. And it didn't take much within that year. I kind of knew that I wanted to go back for a fellowship in non-operative orthopedics. So I ended up doing my primary care sports medicine fellowship down in South Carolina with the Steadman Hawkins Clinic. And after graduating there, I came back up here to Kansas City, and I originally practiced for 3 years with a big orthopedic surgery group in the area, and then kind of broke off to make my own practice because this stuff is kind of more cutting edge and a little bit different of how it works with surgery. And so there, you do sometimes find clinics though that do this stuff in an orthopedic surgery setting, but it's just not really prominent here. It's more on the coasts that you see it.
Yeah.
And places like the Mayo Clinic. Yeah, they kind of use it cooperatively.
Yeah, that's what I was kind of reading up on, just the different biologics. Obviously, I watched you do those procedures, but I know like they're doing like some like the bear procedure with ACL reconstruction, so different things like that. So I guess that's kind of where it might be leading to. But I mean, obviously, you've shown some promising stuff just with all the things you've done and all the things you showed me when I got to shadow you that one day. So obviously, with sports medicine, they're probably going to have more ligament injuries to where they might have to have a surgery, maybe supplemented by that, or can you just use it as a primary intervention to say like a UCL tear or just like a ligament tear of any type? Is there any like injuries where just a primary treatment is like a stem cell or a PRP injection?
A lot, actually. I would tell you probably a majority of the things that you see. So if you look at kind of the history of PRP and biologics, it started in the 70s in animals, like in veterinary medicine. Maybe even people think the 60s. And even to this day, they do it in like equestrian horses and show dogs. But it originally started in the 60s and 70s. And then it was used in oral maxillofacial surgery in humans in the 80s. And then in 1991, you can read different literature, but in 1991 was really the first use of PRP. And it started a lot with tendinopathy because there weren't really great treatments for partial thickness tears or tendinopathy, which, those are two different things. And so those utilizations started there. And then it kind of advanced into where it is now, where, one of the most researched and treated things is knee arthritis, right? So knee osteoarthritis. So it's made that evolution over time. And so I would tell you, with a lot of the things that we see, a majority of it can be treated with orthobiologics, but it's really important to figure out what the patient's goals are, and if they want to have a 15-year solution, then your knee replacement is your 15-year solution.
Right.
For arthritis. If you have a partial thickness tear, then sure, PRP and fat stem cells are your long-term fix for those things. So it's so important. I think I've told you this, to have people come in and do a consultation so that we can, one, make a diagnosis. And a lot of the time I can do that without doing any advanced imaging because I'm trained in musculoskeletal ultrasound. So I call it kind of a poor man's MRI.
It works great.
It does.
You see a lot of things on those.
Well, and there's things you can't see on an ultrasound. So a really good example, that's like a glenoid labral tear. So those are the patients we'll send for an MRI arthrogram, but a lot of the stuff you can see. And in fact, like even tendon issues are really very well seen on ultrasound. So I say, you work things from least invasive to most invasive treatment plans, and part of that is getting evaluated, figuring out what your problem is, and then picking what's kind of right for you.
Yeah. Yeah, especially a lot of those tendons are really superficial. So, I mean, I'm sure they're really easy to scope out and kind of figure out what's going on with the patient. And then, is there like a difference if you would choose to use a stem cell versus like a PRP, say for like an Achilles tendinopathy?
Yeah, that's interesting. Yeah, so like Achilles tendinopathy, if it's really, so I can do this thing where I can check the vascularity of a tendon
Yeah.
on my ultrasound. And if I see that there's very little vascularity, I'll start adding fat to my PRP treatment. And sometimes these look so disastrous, I'll actually do bone marrow with them. It's kind of getting interesting because some of the research out there, they're treating some certain kinds of ACL tears with this, and they're MRIing them 6 months later, and there's ACL
Yeah, that's what I think. There's some new stuff saying it's showing it. I mean, it does just as well as like a primary ACL reconstruction. So,
depending on that, that's like, you gotta be careful saying that stuff because it inflames people, unfortunately. But the data is there where you take the MRI in 6 months on these, non-retracted ACL tears, and their tensile strength is just as good as the native. Yeah, the native, because it is the native ligament. And so, yeah, I think it's kind of you're turning around the Titanic. You're doing a paradigm shift, and that can take a lot of work. The first stuff was on Achilles tendons where there were big ruptures, 80-90% thickness tears, and they were doing just PRP, and the tendon was essentially getting back to over 85% thickness.
That's incredible.
Yeah, it's
pretty incredible. You can just do it with an injection and not have to go through like an Achilles tendon repair surgery, because we all know those can take a long time to repair, and then sometimes they're not successful too. So,
well, and the wild card becomes, it's like, I always tell patients, I'm like, it's like doing IVF, right?
Yeah.
You could take sperm, you could take an embryo or an egg, and you can make an embryo, and then you can put it into a uterus, and you might get a baby 40-50% of the time. So that's, what we do in a petri dish is in vitro. What you do in your body is in vivo. And so you take this stuff and you put it in, and it's relying on the other cells, the native cells that are there, to make that response. And so that response is only going to be as good as the signal that's being put out there.
Yeah. That's kind of like the next question. I mean, so you put these cells into an environment, then obviously, I mean, our bodies are very smart. They can kind of choose those cells, those fresh cells need to be. So how does that go along with like physical therapy and just kind of adding that? When is it appropriate to add that stress? How much stress? And obviously, we want to get them back to exercising and moving. But if you want to go in, just kind of how we can control how, what those cells will differentiate into.
So that's one of my favorite things about when I go to conferences, particularly like there's this group called the Ortho Biologic Institute, or TOBI, and they always have a presentation from at least one physical therapist. And the last one that I really thought was super valuable, now I haven't watched this year's stuff because it just happened 2 weeks ago, but there's a guy down in Gulf Stream, down in Florida, at the Andrews Institute. And he did this like 85 slide presentation back it was 2 years ago, so 2018, about how to rehab these things. And one of the big things he talked about was shear forces. And that they found that if you introduced shear forces really early on, that you actually, you don't move the stem cells, but you create an inflammatory atmosphere that's keeping the cells from proliferating and maturing. And so one of the big tenets have become, okay, number one, avoid those shear forces, which is kind of hard to get a patient to do.
Exactly, yeah.
They're very eager. But the other modalities that I found really interesting, and you guys can speak to this, is blood flow restriction.
Yep.
Not only because of the hypertrophy of the muscle that's going on, but there's some evidence that blood flow restriction actually improves that distal, the growth hormone release distally.
Yeah.
So like that would be your guys' stuff where you can teach me more about that.
Yeah, that's what, I mean, most of my patients get a heavy dose of the blood flow restriction training, especially early on. So, I mean, you can put them on and just have them do like isometric exercises and not really move through a range of motion. Say if we have like a patellar medial facet, if you do a stem cell PRP injection there, you don't want that kneecap moving through the groove to get those shear forces. I mean, you can just put their legs straight and then put the blood flow restriction training cuff on, and you can get them good and tired. You get all the benefits. and the muscles are going to improve. And then that might create a better environment for that stem cell and the PRP injection to be able to kind of heal into it. And then,
well, and 0 of my patients have said they don't like blood flow restriction.
yeah,
It's
and then
100% love it. They want to do it at home.
yeah, I've had a lot of patients, they just purchase their own, because some of those protocols they do like 4 or 5 times a week. So obviously not many people come in that many times, but just for like the general exercise benefit, 2 or 3 times works great. I've had a lot of patients just go by them just because they feel great, and they just want to continue to supplement their exercise regimen with that blood flow restriction training too. So I mean it works fantastic. I mean we have a lot of post-ops that we just use that to help minimize the atrophy and everything, and then it gives them that benefit. They're hurt and they can't really work out, but they get that muscle burn feeling. They feel like they're really doing something, but it's just not fluff. They're actually getting improvement. But then they kind of get that exercise stimulus back too. So that makes them feel a lot better.
Yeah, I'll be interested to see what this last yearly, the conference obviously couldn't be in person because of
Right.
COVID. And
Right.
so they're going to release some of those lectures, and I'll be really interested to see what PT modalities are in there, because that was touted as one of the big lectures, and I'll pass it on to you guys. And we can
Yeah. I remember you sent me that last PT presentation. I really enjoyed reading up about that stuff.
That's the fun part about all of this, is that it's evolving, right?
Yep.
So we're not doing the same thing we were doing 10 years ago.
Right.
We're evolving with it, and we're doing studies, we're doing randomized controlled trials, we're seeing outcomes in patients. And the cool thing is, you get one person who does it, and then they get better, and they tell 3 or 5 people, and those people
Right.
do it. And so it has that exponential spread, and the word gets out there, because just people don't know about this as being an option, as an alternative to different treatment methods.
Right. And that's kind of what I wanted to talk to you, but like, what does the future of it look like? Probably one of the big hindrances is probably it's not covered by most insurances. So is there any updates on just, are they getting on board? Are they reading this research? Obviously, I mean, it's definitely getting more affordable for people, but I mean, that could be an obstacle that people run into sometimes.
I got an email from TRICARE,
Yeah.
Military. They're covering it for knee arthritis. We have not done one for a TRICARE patient, but it's only PRP. So they're not covering fat or bone marrow stem cells, which is kind of interesting, because if you look at the treatments for a lot of the interventions now for knee arthritis, it's not just PRP.
Right.
Because we think of PRP as the growth factor, right? So where's your in quotes seed coming from? And we know that now that's the exosome inside of the stem cell. And so when you see people do these therapies, a lot of them are combining the growth factor with the stem cell. And so with TRICARE covering it and only covering PRP, and I think you've probably seen this, patients who only get PRP, they have this really nice response for about 9 months or a year, if it's in a joint, and then it starts to wear off. In a tendon, PRP works a little bit differently, in that the patient starts to get better at 3 months, 6 months, 9 months, and then they have this monumental improvement after a year with just PRP. There's this great study last year that was published from University of Sydney in Australia, and this doc there, she did PRP on glute medius and glute minimus tendinopathy, which is so common in females between the age of 18 and 80.
Yeah.
Well, they always have that lateral hip pain. It hurts to walk. They Trendelenburg because they're weak, right?
Right.
And she did PRP. She did a randomized control trial where somebody got cortisone, someone got PRP, and the PRPs did even better after a year.
Yeah.
So figuring out the right combination is what's keeping it from being covered by insurance, because there's no standardization just yet.
Right.
I think part of it's that. I think the other part of it is there's no pharmaceutical being used.
Right.
There's no device being used. And so when I hear patients say, oh, well, stem cells not FDA approved, and I'm like, neither is the surgery that gets your knee replacement in your knee.
Right.
The device is FDA approved. So the FDA approves 2 things: devices and drugs, pharmaceuticals.
Right.
A knee replacement's a device. The centrifuge that I use to separate out stem cells and to concentrate platelets is an FDA approved device.
Yeah.
And so you got to think about it. That's one of the hindrances too to getting it covered, is there's no pharmaceutical to this, because the pharmaceutical's coming from you.
Right.
You can't package your cells and sell them to anybody else.
I mean, it has to be. I mean, if it's coming from your own body, then right? How can they regulate that?
Well, and either it's going to work or it's not going to work.
Right.
That's it. So, sometimes I've heard a couple local docs say, well, that can cause tumors. You can get cancer from doing stem cell treatment. That is absolutely untrue. There is no documented malignancy from the use of mesenchymal stem cells, which are adult stem cells that come
Right.
from fat, bone marrow, and blood, and you get some from blood. But there's no documented malignancy whatsoever. So sometimes you have to unteach people.
Yeah. That's one of the fun parts of the job. Yeah.
That's right. Yeah.
So what are yours? So obviously going forward, just taking some common, so all of our viewers watching, so just some things that are pretty common that you treat and that you see some really good success in. It's obviously we've talked Achilles tendinopathy, tennis elbow is another common thing, glute med tendinopathy. Is there any other things that you see a lot of success in, or what are your favorite things to treat?
I like treating all of it.
Yeah.
I really do. But I think if we go from things that are most treated to least treated, it would go knee arthritis, shoulder and hip arthritis, tons of rotator cuffs, partial thickness and full thickness tears. We used to think, oh gosh, you can't treat these full thickness tears, but there's been some data showing if you do bone marrow on those, the patients do really well.
Yeah.
You're not going to grow back that tendon, and even if they're very retracted, you're not going to grow back a supraspinatus tendon, but the patients do it remarkably well. And what they did it for was they were looking for an alternative to repairing the tendon because there were 40 to 60% re-tear rates on rotator cuff tendons. So they said, well, let's try this. So I think those are big ones. Medial and lateral epicondylitis, plantar fasciitis, Achilles tendinosis or tendonitis, tendinopathy, patellar tendon. I've seen a lot more younger athletes with patellar tendon and quadriceps tendon stuff. The young athletes do exceptionally well, and they do well very, very, very quickly.
Yeah, that's awesome. And then, a lot of those diagnoses are just those really stubborn things that, sometimes to rehab those conservatively get tough. So if you can add that just extra benefit and get those results going a little faster, then a lot of people will really appreciate that. But a lot of those are the really stubborn diagnoses to deal with. So if we have some more options of treatment, then I think those would be great for people to know about. Because again, a lot of it's just people aren't quite sure. I always get questions about stem cell PRP. Is it right for me? But there's just not a lot of information out there. So that's why we wanted to get you on. So kind of enlighten everybody on just the benefits of it, and all the conditions that it can treat.
Yeah, you guys do a great job. And the thing is, I know that I've never talked to a PT that loves treating chronic lateral or medial epicondylosis. Sometimes you bang your head against the wall after a while because you got a tendon that's just disorganized.
Right. So,
you got those options of, do you do 10X and start scraping away the tendon?
Right.
Or put PRP and, plus or minus adipose-derived mesenchymal stem cells on there, and do you reorganize that tendon? Because that's what biopsy is showing in all cases. So
that's great. Then it sounds like, just all these different options of what to combine, what not to combine. So, it's just great to have someone that's on top of the research and just on top of all the protocols to, give the people the best shot when you're doing these types of procedures. It's not just a stem cell, not just a PRP. You're going to take what the best options are for that specific condition with all your diagnostic testing, and then get people the best results that they can.
That's right. Yep. And then we send them back your way about 4 weeks post-treatment. Although certain people I've been moving closer to that 2-week mark.
Yeah.
And so feedback from you guys, have you found that doing or starting therapy 2 weeks after is a little more beneficial than 4, or what's been your experience?
I think it could definitely help with the stiffness. And then that's kind of where we've already talked about the blood flow restriction training. We can not really stress the joint at all and kind of let that matrix settle in and, start getting that growth hormone release with the blood flow restriction training, and then start working on the muscular strength and hypertrophy as well. So I think everyone probably agrees that, if we're doing a knee, getting the quadricep as big as strong as possible is optimal. But usually to do that, we have to lift heavy, and there's going to be a lot of shearing going on in the knee joint when we do that. So if we can kind of get that blood flow restriction training started early, just work on early mobility within the parameters, typically they do better. But then some people, just if they're not really compliant, they might have to wait for 4 weeks until they can really start to get back to doing those types of things.
How's dry needling kind of gone alongside with this?
I mean, dry needle, it obviously helps. So, I mean, if there's just a muscle that needs stretched out, but we can't really take it through a full range of motion, then that's just a great way. So, like Achilles tendonitis, like if it's insertional, obviously we don't want to stretch that too much. But, you know, if they have a PRP or stem cell injection into that, but then we still don't want that big compression force when they get to stretch. Dry needling is a great way to get up in the gastroc and the soleus and really help those soft tissues stay good and loose while all that heals. So then they get that feeling that they're a lot looser and they're moving better, but we don't have to put them through a big stretch to get it to that point.
Cool. Very cool.
Great. So how are things going with you and coronavirus? You got a mask of choice?
I do. It's right here. I
Yeah.
took it off. I've been wearing it, you know, you wear it around the bottom of your ears like this.
You might be twins.
Yeah.
I didn't know if you had one with a fancy design on it or not.
No, I don't. But you know, speaking of, it's been interesting. So obviously, I think everybody slowed down around coronavirus. Some people even shut down. But
Right.
that's kind of one of the nice things about doing orthobiologics is that I do all my procedures in my office, so I control my setting. I'm not reliant on an ambulatory surgery center. You know.
Yep.
Oh, this is fun. I should probably tell you this. So I bought a fluoroscopy machine. And we're doing cervical, thoracic, and lumbar injections. Dr. Ackerman and I, Joel Ackerman, who's a pain management physician.
Yeah.
So we're doing injections here in the office now, and we can kind of control that. And we've got the fluoro machine, so that's new, that's fun.
Yeah.
That started right before coronavirus, so we didn't get the word out all that much.
Yeah. Then obviously all the outpatient stuff, or even just people seeking help for their joint pain or musculoskeletal issues, obviously slowed down a little bit, but I mean, that's a great option. I mean, it just expands your opportunity to be able to help more people if you can guide the needle in to kind of get it right into the right spot. So that's awesome.
The goal. That's the goal. Yeah. So you guys are holding up okay over there?
Yep. I mean, we're getting back busy. Obviously, we're just trying to stay as safe as possible and following all the regulations and everything. But I mean, surgery's kind of started back up. So, and, you know, people, they kept working out, and then sometimes just getting some sports teams, you know, they were trying to stay active and everything, but starting back up, we're seeing some more of those types of acute musculoskeletal injuries too. So that's picking back up for everybody. So we just got to.
High school sports is going to be interesting, don't you think?
Wearing the mask and everyone stay safe.
All right. Yeah. Well, we'll see if high school sports start back up too.
Yeah, that'll be another interesting thing. Or even if just professional sports even happens at this point. Do you have a favorite TV show to binge right now?
What's that?
I've watched all my TV shows, so I was wondering if you had any recommendations on your favorite thing to watch right now.
Oh man, I feel like I've been watching a little too much true crime.
Yeah.
Yeah. Much true crime. Billions. We've been.
Yeah, I've heard of that one. Yeah.
Yep. So if you
good actors in that one.
Yeah. How about you?
We just started Yellowstone, so. If everyone's looking for a good TV show, looks like everyone needs to check into Billions and Yellowstone. But I've heard good things about both. So far, Yellowstone looks promising. So
is that Kevin Costner?
Yes.
Okay.
Yep. I thought, you know, he's still alive. I didn't know where he went. He just kind of fell off the face of the earth. Now he's back, and he made a pretty good TV show out of it. So.
Oh, that's great.
Well, awesome. Well, thanks, Leslie, for coming on. Again, she's at Motus Biologics. If everyone has any questions, we'll put her contact information. Again, I got the opportunity to hang out with her for a day in shadow, and there's a lot of good research. She's on top of it. She knows her stuff. I trust her with my knee for sure. So
just to put it out there, anybody's welcome to come and do a shadowing whenever they want to. Come check it out. We'll just have you sign a HIPAA form, and you can come check out whatever procedures, or if you send a patient who ends up getting a procedure and they're okay with you watching, by all means.
Yeah.
Come down.
Well, I appreciate that. I appreciate you taking time out of the day to come on and talk to us, and I think there's a lot of good information on there that people will be able to kind of break down and digest. And obviously, if they have big questions for you just about more of the procedures, we'll send them your way.
Great. All right. Thanks so much, you guys.
Yeah, I appreciate it, Leslie. Again, Motus Biologics. This will be on our YouTube channel. We'll post this to Facebook. If you want to talk about, or if you want to see any of our previous interviews with the physicians, just go check out our YouTube channel. They should all be on there. And Leslie, thanks again for joining us.
All right. Take care.
Yep.